Good afternoon, everybody. So I guess we'll just go ahead right away. So thank you for staying. This is the 5th session and last session of the day. It's going to be basically about tips and tricks and cases. So we'll welcome back Dr. Mohammad Hamady from the Imperial College in UK, talking about aortic or aortic aneurysm, interesting cases.
Good afternoon again. So the few cases. The first case is a 63-year-old female, known Marfan syndrome, with history of type A dissection, history of interposition graft and aortic valve replacement, and pulmonary hypertension. She presented with expanding thoracic aortic aneurysm of 6.8 centimeter. So the section starts from the ascending aorta. That's the entry tear over there, as you can see here. And the main aneurysmal dilatation is in the descending thoracic aorta. My understanding, this is an interactive session. So any suggestion what to do here? Oh, just go ahead. Yeah, it is above the interposition graft. Anyway, sorry. I tried to make the images as clear as possible. The distance between this is a hint, distance between the nominate and the tear is around 28 millimeter.
Let's go to Birmingham.
Thank you. I guess this is going to be, you're a radiologist, this is going to be an endovascular solution. Deploy a short endograft cuff under rapid pacing to deal with that entry tear.
Yeah, that's absolutely right. But which cuff are you going to use?
The Cook ascending device, if you can get hold of it.
Okay.
Is it?
Well, before you go on, Mohammad, what are the possible technical difficulties in actually securing a cuff position at that location for the tear? And do you do these under complete cardiac arrest, or what do you do?
Yes, I mean, the difficulty here, if you're putting a short stent here, you are between the nominate and the coronaries. So you don't want the stent to jump back to cover the great vessels, and at the same time, you don't want to cover the coronaries. And the other difficulty would be the wire, because to put a wire through the aortic valve, one needs to be careful with it, and needs to have a good collaboration and communication with the anesthetist. This patient had a custom-made device from Bolton, and the benefits from it, because it does not have a bare stent at the top of the stent, and also it is reverse tapered, if you can see, because the diameter of the aorta at this level is different from the diameter of the aorta at that interposition graft. So we thought this is an added advantage of a custom-made Bolton device, and this was deployed under overriding pacing, good position. The false lumen completely thrombosed, and the patient had paraplegia because it was so effective thrombosis of the. We didn't do it with a spinal because we thought, well, it's a short segment, it's in the ascending. Here, eventually, I mean, luckily recovered, but that was the outcome of the case.
So how long did it take the company to produce this custom-made graft?
6 weeks.
6 weeks? Did you feel that there was any danger in the patient and, waiting this period? I mean, this is an acute dissection with quite a large...
Sorry, it's not an acute.
Quite a large...
It's not an acute, it's a chronic.
Oh, this was chronic.
Yeah,
I'm sorry.
it's already treated.
Apologize. We'll hear from the surgeon.
Two questions. I mean, other options to go transapical. I don't know if you had this experience or not, you know. Go transapical through the heart, the right atrium, the left ventricle. And you
Transapical.
deploy, yeah,
Transapical.
transapical, you know.
Yes, I know.
With these options. The second thing, we have a similar case, but ours was more difficult because he has an aortic valve replacement. It was metallics. So the problem is that the device has a cone, and we cannot pass the cone through the valve because it's a metallic valve. So what happened is that we cut the cone. It's not recommended, but we did, and it worked, you know, just to comment.
Yes, I mean, I agree with you. This can be challenging. This is not the first case. We do stenting of the ascending aorta, and always that olive can be a challenging thing. We tried an olive oil shaped tip of the stent from the same manufacturer. It wasn't really helpful. The Gore is the famous one of having short tip, but we thought in this case, because of the difference in the diameter of the aorta at short distance, we thought that if we have a custom made with this reverse tapered, that would do the job. But obviously, you can use other devices. It's just the concept that we look at the dissection, even if it's type A, but sometimes, if we're lucky, we can find the primary anterior tear, and that can have good results to cover it.
Just generally speaking, you know, if we have the indication for treatment was the aneurysm dilatation of the false lumen, and many times, you know, you cover the anterior tear, but you know, there's some other tears that show up. So for generally speaking, we end up stenting, you know, almost the majority of the descending aorta. I mean, in this case, you're stuck because of the arch. I mean, probably in our situation, this will get a total arch repair, then elephant trunk, and an extending distally. But one other approach, if this patient is not a surgical candidate, is to do you know, stent graft of the arch, and then do a carotid and carotid subclavian as needed, and had some indominant snorkels. So there'd be one approach for this, because just fixing the ascending, I'm not sure if the descending is not gonna continue to grow down the road, and seems to be even covering the anterior tear that you need to do some other work. So I don't know if you have any comments on that.
Yeah, I mean, absolutely right. I mean, to do neonominate with a bifurcation to the carotid is always an option. The problem with that you need a good thumbprint. So you need around 2.5 centimeter thumbprint for the neonominate. And if you are an interposition graft of 4 centimeter, you don't have landing zone. So this was considered, but we thought we dropped it because of the short segment. Yes, you're right. I mean, we're covering the anterior tear and we're leaving the rest of the aorta. But we thought this is the best option to stabilize the disease there, and he is under follow-up, or she is under follow-up. And she's Marfan by the end, but probably will end with a total replacement if she survives long enough. The second case is a 50-year-old female with 5.8 centimeter penetrating aortic ulcer. The penetrating aortic ulcer, the mouth of it is at the level of the left subclavian artery. It's where the cross is. The distance between the left subclavian artery and the innominate is around 18 millimeter. And the distance between the left subclavian and carotid is around 12 millimeter. So it's a very short, very tight landing zone. Any suggestions?
Carotid bypass initially, then put a endograft covering the left carotid artery.
Yeah, that's a valid option, but we chose a different one.
Mohammad, before you go on about the options, the location of the aneurysm in these cases of a problem, being kind of not quite, it's a localized aneurysm rather than a diffuse aneurysm. And at the placement of the stent graft, in these cases, more difficult so that you can actually cover the area adequately, provided that you have a good landing zone. Is this a consideration at all?
The landing zone and creating it is probably a secondary issue. It's more when we have a saccular aneurysm of this shape, we are really anxious. And even if it's 5.8, we usually treat 6 and above. But even with 5.8, we thought, because of the shape of it, we should be treated. Now, the landing zone is another issue, and we went into, or we decided to go to a less invasive option than the carotid bypass and carotid subclavian bypass. We chose a custom-made device with fenestration and scallop. The fenestration to the left subclavian artery, and the scallop was a deep scallop, so from the same manufacturer of previous case, which incorporate both the innominate and the left common carotid artery. This was stented, and this is the final product. Got excluded, and the subclavian and carotid preserved. The following case is a 77-year-old male post-TVAR and EVAR in another institution with endoleak in the thoracic aorta and endoleak in the abdominal aorta and endoleak in the distal left common iliac artery. So he's a man of endoleaks. The diameter of the thoracic is 8.9. The diameter of the abdominal is 6.5. For the sake of time, the cause of the endoleak in the thoracic aorta is type 2 from intercostal bronchial branch, and the cause of type 2 endoleak in the abdominal is from the IMA, and the common iliac is growing of the, this is a flared leg, which is not engaging anymore. So obviously we're going for the larger aneurysm to treat. This is the angiogram, which shows the intercostal bronchial supplying the sac. We're going to embolize it. Any suggestion which embolic material?
I believe Onyx is now becoming more frequently used. Is this your experience?
Sorry?
Onyx is becoming more frequently
yes.
used. Is this your experience?
Yeah.
Do you have any experience in the audience?
Yeah, I mean, most of these are we treating with Onyx now, and either transarterial or direct stick, and even for type 1 sometimes trying to sneak next to it. So I'm assuming you're going to show us an awesome Onyx case now.
No, we went for Onyx, but the Onyx didn't work. I spent 2 hours, and I couldn't advance it beyond that point.
Ahmed, I have a question to ask. I'm sorry if do you have it?
After you, no problem.
The problem with the intercostal branches, the upper intercostal branches, is the common origin of spinal artery, accessory spinal arteries from these. Using liquid material, is this something that you would worry about, or?
I think I mean, you're absolutely right. And my first angiogram, I was looking at the anterior spinal artery, which is luckily I didn't see it, so I assumed it's not supplying it, and it's not supplying it, as proved later. But the Onyx, I think, because of visibility and more or less very good control over it for the operator, you can control where it is going. Now, my problem here, I couldn't advance the microcatheter far in, and I couldn't push the colon of the Onyx despite waiting for a long time, the same technique they use in the neurointervention. So we left with untreated type 2 endoleak, and we used the, sorry.
Why did you want to treat to start with?
Expanding is 8.9.
It's expanding, okay.
Yeah, and it's 8.9.
What?
And someone told the patient in the clinic, was sitting on a time bomb, so we have to treat it.
I have a question.
Sorry? It makes sense. Yeah.
Excuse me, I have a question here.
Yeah, sorry.
Yeah, just what about direct puncture in this situation?
Sorry?
Percutaneous direct puncture in this situation?
Yeah, absolutely right, and that's what we did. We used the expert guide in angio suite with the, obviously, knowledge of the anatomy, where the endoleak, and combined with the fluoroscopy, we punctured directly, did angiogram, and it is very impressive outlining of the blood supply to the sac, and we filled it with onyx. But that's from the percutaneous approach. Then we went into the IMA and selected the IMA, went into the sac, filled it with onyx. It's a bit tortuous line, but eventually managed to do it with good results. And the distal, or the type 1B, was treated with stent and embolization of the internal iliac. The next case is a 55-year-old male with history of type B dissection, treated with TVAR, complex cardiac history, recent presentation with expanding thoracoabdominal aortic aneurysm, and it's 8.1, and it's expanding, and there is a very good backwash into the descending, in the false lumen and the descending. The infrarenal aorta is not aneurysmal. It's slightly aneurysmal. It's 4 centimeter, but the main aneurysm, which is 8.1, in the descending. So, any suggestions?
Where do you think your main fenestration is? Is it infrarenal or at the ostium of the...
Sorry.
Where do you think your main fenestrations are now, the filling? Is it usually at the renals? Is that what you think they are, or at the SMA origin?
That's a very good question. There is a main one around the renal, but there are multiple. And it is not shown here. We stented the left renal, but it didn't make a difference.
Didn't work. I mean, you know, sometimes if there are no fenestrations between that and the celiac, seems the extending to the celiac is not going to help. So, again, I mean, I would say in our situation, we'll probably extend it to the celiac and they get an abdominal repair, and then, you know, to suture to the stent graft, and that'll be the way to get rid of most of these fenestrations.
Sorry, suture to what? Sorry?
So basically do a surgical approach, basically by extending the stent graft to the celiac and then do an abdominal repair, basically do a hybrid, and, you know, so the surgical graft to the stent graft, and that's the collaboration we have with our surgeons. We extend it to the celiac and do it that way, and this way you close all the fenestrations in abdominal.
Yeah, it's a good option. However, there was a reluctance to do hybrid because it's 4 centimeter and he is young. And to subject him to the risk of hybrid was probably not justified if there is something else that we can do with a bit of onyx here. And the follow-up CT was sorted. It is not obviously a definitive treatment. We're keeping him on follow-up and waiting for another indication to do the hybrid that you mentioned.
Another option which I've used for a rupture, one of these, is to use an aorto-uniiliac converter, depending on the size of the false lumen. I deploy that and then put an iliac zip plug inside the 12 millimeter part of the AUI converter, and that will close off your false lumen.
Yeah.
It depends on the specific anatomy.
That's right. What size do they go to?
36.
36.
Yeah,
that's
can I ask you a question with this method that you've used? Sometimes the problem with these is that actually both of them have circular or elliptical shape, and the leak persists, you know, at the
around
junction,
the side of it.
yeah, between the two.
I think between the AUI converter and the zip plug.
Yeah, because the outer diameter of the original stent and the outer diameter of the converter both are either elliptical or circular, and you have this dead space or a space between them that's not filled in. How do you overcome that problem?
I've only used it once and it worked, so I've yet to overcome the problem. The other thing to do would have been to put a fenestrated device in, of course, and seal in the infrarenal aorta. And if there's any further tears lower down, use covered stents to close a tear in the external iliac or wherever.
That's a good option. I'm not sure about the anatomy of the visceral arteries, but yeah, absolutely. The other case is a 38-year-old, that's the theme today, Marfan's patients. Complex surgical history, type A dissection with ascending repair, previous partial hybrid revascularization, and an outside center for the celiac trunk and SMA, and there was left renal stent, cover stent already inserted. She presented to us with, again, expanding abdominal and thoracic. She had the rest of the hybrid, that's revascularization of the 2 renal arteries, and stenting to the common iliac arteries on both sides. My surgical colleague said he clamped very well the left renal artery, a stent, but that was proved to be not the case. So there is, the clamp probably got loosened, and there is still endoleak, which I don't know what to define it's to, but it's really significant too. And because the patient is anxious and is already and was unhappy with the other center, so we had to finish the job. When I went to the spaghetti graft and used the robotic catheter to go and select one of the spaghetti grafts, which is the renal one, and then advance the robotic catheter into the renal stent and through it a microcatheter, and we filled the stent with coils and onyx with good results. We still have time now.